So welcome everyone. We are so glad you joined us today. Very excited to introduce the moderator for today's session. The session for today is very exciting because it's the first session of VLC that we've done something like this. So it's working in coalition to advance viral hepatitis testing, SSPs and MAT settings, and it's made possible in partnership with CDC's Division of Viral Hepatitis. So my name is Isabella Chuga. I use she, aya pronouns, and I'm part of the hepatitis team at NASTAD. So like I mentioned, joining us today is the moderator for today's session, Heather Bush, who is also part of NASTAD's HepTAC Advisory Committee and is also the HIV Prevention Manager with Utah Department of Health. So today we will begin with presentations by Melissa Hobkirk, who is the Viral Hepatitis Prevention Policy and Community Outreach Manager with the Philadelphia Department of Public Health, and Lauren Orkis, who is the Viral Hepatitis Epidemiologist with the Pennsylvania Department of Health. So we'll start hearing remarks from them, presentation, which we're very excited about. We'll shift between each other, and then we'll have a Q&A discussion towards the end. We're hoping to save about 20 minutes, which will be moderated by Heather. So feel free to use the chat to introduce yourself and ask questions. And I think with that, I'm turning it over to Melissa. To them.
Thank you so much for having us today. We're excited to share a little bit about our work at PDPH. So when we are talking about Hep C testing, we can't just say, hey, implement some testing. It's a little more complicated than that. And so we really would like to share with you some of the systems that we went through to be able to implement the testing. It involves things such as staffing, workflows, a linkage to care, et cetera, just to get to that Hep C testing point. And once that testing is implemented, we can't really stop there. I mean, we want to talk about, are we providing linkage to care services? Are you testing? Are you providing treatment on site? Are you referring out? And so it really becomes a little more complicated than just Hep C testing itself. So we took all this into consideration at PDPH while we were working with our partners to support their Hep C integration. And we are, of course, constantly learning from our partners and happy to share that with you. So the approach we took for Hep C advancement is 3 different levels. The first one, we took a macro level support system, and this is really the gold standard, right? I mean, we want systems level change. We want to remove policy and insurance barriers to testing. We want to make it easier for providers to implement and therefore more willing to do so. So this systems level change is also kind of easiest without dedicated funding or staff. And it also takes forever to affect change. And I think working for a health department, you kind of are in tune with how long things take. So we're good people to do that. And then the mid-level support we offered, think more along the lines of clinic and hospital systems, and tried to hit some of those larger safety net sites while affecting change within genres of providers. So like a spiderweb approach. And in addition, we worked within our own health department to explore ways that we could work with other programs and find out what they were already doing and how we could insert ourselves. That internal collaboration doesn't really cost any money. It might cost a little bit of your morale, but it's totally worth it. And then the micro level support we got into was more the medical and social service location, so site specific support. And this micro level support is something that helped us, of course, to stay grounded and stay connected and use that information that we learned to then inform our macro level support. So knowing the information of where the barriers exist and then how to implement those changes at a macro level. And, keeping in mind the examples I'm about to go over here are Philly specific, but all of them are totally scalable and just examples. I mean, it's just a variety of ways that you could also do this in your own jurisdiction, and just trying to really leverage your position as a health department employee to access like workarounds and loopholes, and also those existing health department activities and partnerships within the community. And so again, all of these are interconnected. Each level of change feeds into the next and is dependent on the prior. And so we'll really talk more about that as we go on here. Okay, so jumping right in here. So macro level changes. So knowing your decision makers and knowing the issues. So as health department staff, you know people in high places, you know people who know people in high places. And you also understand how decisions are made. And so once you figure out to whom your request should be directed to advocate for that change, utilizing that micro level relationship building to really inform who you're talking to at the macro level and what changes you want to happen. So for example, a lab report showed us that there were antibody tests being ordered, but no RNA tests from MAC clinics. And so we asked one of those MAC clinics we have a relationship with, why is this happening? So we're getting antibodies, but no RNA testing. And we found out that the MCO was not reimbursing the RNA tests. So we were able to talk to the MCO and explain why it's important to pay for these tests. And so now they are actually reimbursable. So that is just one example, of course. Another way to support macro level change is talking and working with local coalitions and community partners to try to affect some policy changes. And I know that that might be difficult depending on your position within the health department, but if there's any kind of support that you could offer. For example, we provide administrative support for one of our local coalitions, and then also we're able to provide, be a liaison for the health department to inform the community what is going on at the health department level. So mid-level changes. This is, I think, probably where we're all going to be most effective maybe. And that's just taking a look at the data you're already collecting and using care cascades as tools and not just a box to check for CDC facilitate a venue for idea sharing. As a common gripe with some of our partner physicians is that they had no idea what was going on across the city. And so we facilitate that venue using component 3 funds to host a technical advisory committee. And what we're learning within that technical advisory committee, we're saving and creating a provider toolkit because we want this to be replicable. All right, so micro level changes, which cost money, it costs time and staff. So this may not be feasible for all jurisdictions here, but maintaining a dialogue with clinics and community organizations who are providing the Hep C testing and services is really important. One example, we were able to, out of regular discussions with one of our MAC partners, support them in a 340B partnership, which is of funding their service integration with viral hepatitis, HIV, and PrEP services. And we've continued those discussions, and they also continue to inform our macro and mid-level changes. So another example would be our technical assistance, again, provided through the Philly and Sync project, which is component 3 funding. We can work directly with a syringe service program and a MAC clinic to provide that one-on-one technical support. And shameless plug, if you can tune in on August 12th for our presentation about our component 3 funding. If you are unable to attend, please feel free to contact us offline for more details. Another example that we are doing linkage to care and navigation. We were able to partner again with our substance use and harm reduction program to identify people living with Hep C who also have substance use disorder and connect them with co-located treatment sites. And that has also grown into identifying a provider network that is really PWID friendly and one that we've been able to share more broadly across our community. I'm going to hand it over now to Lauren.
Thanks, Melissa. Okay, can you see my larger screen now? Are you seeing my screen, Melissa?
Yes.
Okay, great. Perfect. All right, so thanks again for the invitation to speak today. Melissa and I decided to collaborate on this just because I think it's nice to highlight the collaboration between the local jurisdiction and the state in Pennsylvania, but also to highlight how we collaborated in this space to learn from each other. So Philadelphia has so many years of experience in this space, and to highlight the state's experience is, I think, helpful for folks to realize how you can sort of translate it to a landscape that's not used to this integration. So I've just been so fortunate to be able to collaborate with PDPH so closely, especially on the substance use sort of end of the integration. So I'm going to be talking today a little bit about our work on the state opioid response grant, HIV viral hep sub-project of that larger SAMHSA grant. And some of our approach really was born out of conversations that we had with folks from PDPH about their past experience, specifically in MAT settings. So thanks to Melissa for presenting first there. So just overall, I'll be talking through, our sort of approach to this call in the state opioid response grant, and review a little further down how this work aligns with elimination planning that we've done statewide. And specifically at the end, I will highlight some collaboration with SSP advocates on elimination planning to then transition us into a further discussion with Melissa. So just to start, the State Opioid Response Grant has this sub-project that basically directs, in our state, our Department of Drug and Alcohol Programs, or what we call DDAP, to integrate HIV and viral hepatitis services in their licensed infrastructure. And so we heard about this in the summer of 2020. From the Department of Health's perspective. So we worked closely with DDAP to determine how the funds could be used to meet the directive from the SAMHSA grant, but it was quite a whirlwind process. I'm really interested to hear some other folks' perspective when we get to the discussion portion of this, as I'm just always curious to see how other states are involved in this national grant. So specifically, the grant language within this sub-project is very broad. It's basically you are meant to integrate these services. You're meant to offer testing and linkage to care to all clients within the infrastructure, testing and linkage to care specifically for HIV and viral hepatitis. It doesn't specifically say Hep C, it does say viral hepatitis, which is nice. And we are trying to do that through prevention, testing, education of both the client and staff, and set up some interventions through TA, and ultimately hope to get some facilities to on-site HCD treatment. Our contractors on this project developed this visual, which helps people kind of digest what is possible in this landscape. So it's a tiered sort of approach of assistance that is being offered through this program. So, you know, the low-hanging fruit, of course, is the education piece. We have really had some great buy-in across the state on folks wanting this very up-to-date and detailed education that really doesn't exist to the extent that you expect. Then we're working towards providing curriculum, whether it be group session or individual session type curriculum, and updating materials that are provided to clients, and making that available to the individual treating facility, SUD treatment facility. Then, you know, ultimately working to hopefully on-site treatment and prevention and harm reduction. We still don't have statewide legal syringe service in Pennsylvania, unfortunately, but we are, knock on wood, close there. But yeah, so we have a tiered approach because the, I think, unique angle that we're going out with this state opioid response grant project is that we're trying to reach all levels of care. We probably, in retrospect, should have just tried low-hanging fruit engagement with more medically centric treatment settings, being those that offer MAT. But we felt like we really couldn't leave out those more, you know, outpatient or detox facilities that definitely need the education for sure. So we've bitten off a lot, but it's been an interesting process for sure. And we've definitely been encouraged by DDAP, our drug and alcohol partners, to go at this project very broadly. So we were tasked to implement this through what we call our single county authority structure. And I'm not sure how other states are set up, but we, in our drug and alcohol landscape, the dollars sort of funnel through these single county authorities, which is sort of a misnomer. We have 67 counties in Pennsylvania and 47 single county authorities. So several of them are conglomerates. But we've had great engagement thus far. So the single county authorities are sort of our launching point to then get to the individual treatment providers, and 94% of single county authorities have engaged us on this project, and DDAP is trying to help us with the remaining. To date, we have held several different types of meetings with these SCAs and ultimately gotten to about a third, providing about a 3-hour, very intensive HIV and viral hepatitis sort of overview training for their individual treatment providers. So we're getting through those that have been scheduled thus far through scheduled into the fall. We were also tasked with coming up with sort of an infrastructure toolkit so that if these dollars were to go away, we would be left with a product that folks would be able to utilize in our absence of the sort of contractor support that's funded through state opioid response grant. So we developed several different pieces of this toolkit and built upon existing materials such as educational materials. The first being a capacity assessment, so I'll walk through that first. This is a tool that I, from where I sit in the epi world, wasn't really aware of this type of template, but it's a tool that's used, I think, across the board with drug and alcohol facilities in terms of assessing capacity. So we're actually assessing the program's capacity to integrate these services. So it's basically a rubric for our contractors when they get to the individual TA level to help them measure success. So this is, I think, a really useful product that we much willing to share if others are interested in that. And we have yet to really test it yet on the individual level. We haven't gotten to the TA piece. We're working through that in our next year, really individualized TA, but I'm excited about the opportunity here. It has several different domains and it basically gets you to a score, and we don't want to, have a negative perception of grade, but it is helpful to really measure change. We also developed what we are calling kind of screening tool to determine if services are needed. This was such a sticking point here at the beginning of really trying to get this off the ground. It seems so simple that you should be able to offer services to anybody coming through the door of a substance use disorder treatment facility. But we were really trying to meet programs where they were at and anticipating that folks would have trouble offering services to everybody coming through their door, given we're trying to reach all levels of care. But ultimately, when it came down to it, we really are trying to make sure that we are emphasizing opt-out testing for everybody that comes to the door, and making sure that services being offered are uniform and just best practice. We're not trying to score anybody in terms of risk. We were trying to stay as far away from that as possible, but we can have an entire conversation about that because risk assessment is embedded in the DNA landscape. So again, we have this tool that when it came down to it, it's pretty simple, but it's based off of actually language that our drug and alcohol program partners put down on paper into this manual, which is updated every couple of years. And we were lucky to be able to be a part of the update team last summer. So that really helped us move the needle in terms of what folks were required to do. We also were tasked by our drug and alcohol partners to write some protocols for actually how to do this. And this has been one of the more difficult pieces. We definitely have drafts started, but we are going to be implementing more of a work group model to finalize some of our protocols so that we have as many partners at the table as possible. So it doesn't appear that we're putting down a directive, but we're also listening to the partners that have experience in this space and understanding that there are lots of barriers to actually implementing this. We also provided some educational materials at the top of this project, just utilizing what was out there from CDC on several different topics, because so many of our treatment providers that were initially really excited about this wanted materials immediately that were updated. Since then, over the last couple of months, our contracting team has provided some educational materials that are more state specific. So our dollars through SOAR have really helped us ramp up some of our educational materials that are available. And we also are finalizing what we're calling a referral guide or directory of services by single county authority. So regional sort of directories. And shout out to Lindsay in Tennessee had shared their template of for their DIS, what their referral guide looks like. And that's been super helpful for us to build off of. So this is something that is a critical piece that I think definitely helps us move the needle in terms of getting information in terms of what the landscape looks like for HIV in a centralized place by region. That doesn't really exist, but the breadth of information for HIV, really is much more encompassing than it is for viral hepatitis. So the fact that we're able to spend these SOAR dollars to help us understand what the network looks like for viral hepatitis is just mind-blowing that we're actually able to do this. So our contractors are working really hard on providing HIV and viral hepatitis services by single county authority. So we're just really excited about that piece there. We also are working on a psychoeducational curriculum. This is a group setting type curriculum or individual setting curriculum. And so we're building off of educational materials that have been developed, and this should be, really, really nice free resource for treatment providers. We also are developing trainings. As I mentioned, when I had mentioned the meetings that we were having by SCA, a lot of SCAs had asked for this updated and more in-depth training on HIV and viral hepatitis. So we're kind of developing these trainings threefold. One 3-hour training for licensed clinicians And those folks are actually required through our drug and alcohol partners to take a one-time HIV and viral hepatitis training, but that could be, X number of years ago when they were hired. So this is a really nice opportunity to update folks on where we're at with HIV and viral hepatitis. Testing leads to care and treatment. So there's the licensed clinician part, and then we decided to do a 2-hour training for more of a community audience. So those that don't have the requirement of this training by our drug and alcohol partners. So more, peer recovery specialist, case managers. And then we have a third facet of training that we're working on for more of a medically centric audience, and hoping to then train folks to actually offer HCV treatment on site as part of this. So I did also want to highlight, as part of SOAR, we were able to utilize these dollars to develop a digital media campaign. The dates of when it'll run have been altered a bit, but it actually just went live very recently. So I'm going to try to share another screen to show you what this looks like.
Testing for HIV and Hep C does.
Can you hear that? Or do I need to share my sound?
Yes, it works great.
Good, okay.
Scare me. Why? Because I know they're preventable viruses. And today we can prevent, test, and treat HIV and Hep C. The facts kicked my fear to the curb. Don't let the unknown scare you. Get the facts. Paid for with Pennsylvania taxpayer dollars. Testing for HIV.
So we were able to develop this digital media campaign that's running on a couple of different platforms, and it'll run through the end of the summer. Yeah, I could go on and on about this piece. This is a really unique way for us to combine messaging for HIV and Hep C. So excited about that opportunity, and I included the links here. It's, as I said, just recently it went live. And the last piece is just, what we're hoping to really get off the ground as part of the actual sort of resource offering in the next couple of months is, of course, some test kit distribution. We wanted to stay away from this at the beginning. We're really trying to get people towards blood draw on site. But again, just trying to meet people where they are as a first step. We are going to be offering some test kit distribution as well as vaccine distribution. And then again, as I said, in this third year, we are going to be getting to the individual level TA, which I'm excited about. We've heard from our single county authority partners just some feedback to really incorporate for our third year, thinking about how to involve criminal justice in this work. We know that folks are in and out of jails and prisons that are interacting with these programs. So keeping that in mind and thinking about better integration with those programs is always important. We've had just a mountain of payer issues that we haven't even gotten really to the individual TA. And I know this, we're just preemptively trying to address these issues that we know really prevent folks from offering these services on site, because we have a very pronounced split of behavioral health and physical health in our state. We also have heard from single county authorities just about the need to really increase awareness amongst clients and staff. So just improvement of education across the board. And then this gets to sort of some of the payer concerns and also access and availability of services across the state. We know this is an issue, and we'll be working through this a bit, I think, with our referral guide as well. So that's sort of the end of the overview of the State Opioid Response Grant work. I did want to just briefly highlight that the SOAR funding really has critically allowed us to move the needle on a couple of different pieces of our elimination plan. We published that back in March. And so we've gotten a lot of buy-in from our drug and alcohol partners at the state level to continue this work. We've been working with them on an implementation plan to make sure that we have a more sustainable approach beyond even the SOAR dollars. So that's been really positive. And it wouldn't have been without SOAR that we would have even had that conversation. So very positive there. But also related to elimination planning, we hosted an event in early June that highlighted the publishing of our plan. And we had planned this in partnership with our Hep-Free PA Coalition. And we had, everything in place to really get it off the ground. But it ended up that the Secretary of Health in our state was supposed to speak at our event. And then she was also supposed to speak either a day or two later in partnership with some SSP advocates, because we're still, as I said, trying to get legalized syringe service statewide. And so we decided to combine forces. And that was so positive, I think on multiple fronts, but especially on our front. I just wanted to highlight the agenda here and just the amazing collaboration that came out of it. And hopefully will lead to additional collaboration as knock on wood we get to legalize syringe service statewide. As I imagine, hepatitis folks will always sort of be in the fold with the SSP landscape, but I am just anticipating the question of, well, now where should they be statewide? So always looking for continued collaboration there as we hopefully move towards legalized syringe service. And I have my contact information here. Feel free to reach out.
Awesome, Lauren and Melissa. That was so great. I had a little bit of a preview, but that was amazing. Excellent. So I've been picking up some questions from the chat, as well as I have some questions of my own. But I did just want to start with, in the chat, a few people, Lauren, wanted to know if you could share your rubric, as well as the referral guide and a link to your media campaign. Those are all things you're willing to share? Okay, great. Do you want to share those with Isabel, and then she can share them with the group? Does that work, Isabel?
Yes.
Excellent. Okay. And then someone also asked if you did you use the SOR funding for the media campaign? Was that part of it?
Yes. Yep. And I actually was able to get our drug and alcohol state partners to pay for it outside of the pot of money we had for HIV and viral hep. So
nice.
They're sitting on a lot of money and they're looking for ways to spend down. So it was a good collaboration there.
Yeah, and I think that's often the case. I say often about the SOR funding, you just ask. Ask, and they may be able to utilize it in ways that they haven't even thought about. So that's great to hear. And then you had said that you wanted to hear more about maybe how other states are utilizing SOR funding. So I think that's our first discussion question. Do any of
Heather, I don't mean to interrupt, but we had a little bit more to talk about with the syringe service programs.
I'm so sorry. I just jumped in.
Okay.
I was so excited. Go ahead. Go ahead and complete talking about that. And then we'll jump on to the SOR questions or the discussion questions. Sorry about that.
Okay. Thanks, Heather. I'll make it quick. We'll be brief. Just I guess to piggyback on what Lauren was saying when she was talking about advocating for our syringe service program expansion here in Pennsylvania, we really can't integrate testing into locations that don't exist. And so first we need to create syringe service programs. And so it's at PDPH, we have found this just crucial. And so we've done what we can to try to join Lauren and join the PA Department of Health in supporting, advocating for expansion of syringe service programs, and hopefully, this is a big policy time for us. So hopefully that will be expanding in sooner rather than later. So a mid-level change that we worked on with SSPs, we partnered with our substance use and prevention and harm reduction to provide data that informs where they're placing their mobile units for testing services. And we were also able to work with our SSP and a local hepatitis B organization to test for infection and immunity to Hep A, B, C, and D, and then link people to care and or vaccination services. And that was called our alphabet study. And then again, with provider education, we were able to collaborate within the health department to provide some bupe training, which ended up blossoming into this whole person health focused education series with our substance use and harm reduction team. And then of course, we're always referring people in any education that we provide, referring people to our syringe service program location. And then at a micro level, we did supply staff to provide phlebotomy services at Prevention Point Philadelphia until they were able to fund their own staff there. So, okay, so all this said here, you know, the real mid-level change is coming from the health department itself. We're all in the same boat, we're all bailing water. We have no staff, we have no money, but we're all willing to work. And it just seems like this might be a great way, I mean, to have the most impact, and it's free. So looking around and seeing what's already happening and snooping around your office space, learning what other programs are doing, and not necessarily viral hepatitis related, but think broader, like what are programs doing? Are they working with people who are unstably housed? Are they working with people who use drugs? Do any programs use outreach staff? Are they linking people to care? And just learning the systems in general that can give you a clearer picture of what's going on and really offer the opportunity to slide into people's DMs and try to figure out eventually how you can collaborate down the road here. And step two, what can you offer these programs? So try not to come to the table empty-handed, maybe. The elimination plan has been a really great way to bring different players within the health department together to sit down and talk about hepatitis, viral hepatitis, but offering people just educational materials, education for their staff, offering your eyes and ears to look at their materials, and then eventually using all of this to figure out a way to collaborate. That's introducing each other to community partners, providing navigation, sharing what data you're collecting, et cetera. And then not only at the health department level, but your hepatitis program itself. So leading by example within your department, patient-centered, whole person care, where harm reduction and cultural competency are embedded into every piece of communication that leaves your program internally and community facing. I mean, this means promoting providers who are PUID friendly without saying it, providing co-located services. There's an example on here of a palm card that we have, or a quad fold card that we have that a lot of other programs within the health department are now using. I mean, we can't talk about viral hep in general, and certainly not hep C without harm reduction. And so it's really important that we are leading language, I think, within our departments. And I mean, food for thought here, our substance use and prevention and harm reduction program grew out of the hepatitis program. So I think that, you know, knowing that syringe service programs aren't legal everywhere yet and being ahead of the game by being prepared is really important. And then just some key takeaways, that all of these different levels of changes are completely interdependent. Collaboration within your health department is ideal. And then using your unique position, leveraging that position of working for a health department to talk to your decision makers, staying in contact with community level organizations. And then if patients, everything takes time, we know that. And then contact information. If you need a pep talk, want to troubleshoot, want to chit chat, please reach out. PDPH HEP team is always here for you. So thank you so much. That's it.
Okay, now we can jump into discussion questions. Do we have anything right off the bat for Melissa or Lauren? All right, Amelia says, for Lauren, are the trainings you do live or do you have a platform with modules? It's a good question.
They are live. So
Nice.
we felt like that was really important. And our contractors really wanted to go on site, but only maybe 10% wanted on live on in person. But
So they're live but virtual.
Yep.
And how often do you do them?
We are doing them, scheduling them by single county authority. So we have 47 of them to do. And then several SCAs also wanted to offer multiple sessions. So it's quite an undertaking at 3 hours pop.
Sounds like it. So I think, yeah, so that's one of the advantages maybe to having some of it pre-recorded or in modules, is that it's not quite as, but then it's not as personal. Great. Anybody else have any? Oh, here's one from Kaylin. Who or what type of contractor do you use for those trainings?
Yeah, we were already connected with a group at Penn State through a project that they run called the Pennsylvania Expanded HIV Testing Initiative. So we are primarily contracted with them, and it's really only a couple of folks, professors and instructors and their grad students. And then Penn State is subcontracting with the Health Federation of Philly, so Stacy Truskin's group that they call Sea Change.
Okay, great. Have you noticed any differences in working with methadone clinics versus Suboxone providers?
We haven't gotten there yet, so I wouldn't be able to say, but yeah, hopefully in the next year we'll have an answer.
Yeah, that's a really good question. All right, any other questions from the group so far? Excellent. Well, I'm going to circle back around to how have other states utilized some SOR funding to work with MAT or SSPs? You can either take yourself off mute, raise your hand, jump in the chat. Yeah, Emily, she says we can't get access to any of the SOR funds, and she's tried repeatedly. I think that's really what's interesting too. It seems to be a lot about your relationship or the people in your state who are overseeing that. Because we've had the experience in Utah that they almost throw SOR funds at us. Like you were saying, there's so much of them. Oh, good. Shannon had said that they've just started conversations with SOR this week. And Amelia,
sorry, to Emily's point, and others that have said the same, I just don't understand how the drug and alcohol folks are carrying this work out if you're not doing it in partnership with Department of Health. Maybe they're not carrying it out. What are they doing? I don't understand.
I mean, they're doing other things with opioid treatment programs, but not the intersection of infectious disease and opioid treatment programs. So they're doing a lot of things with the money. It's just nothing that supports our infectious disease goals. And it would be nice if there was a federal requirement that the SOR dollars had to be used in part for this kind of work. But, you know, they keep telling us all the money's accounted for. There's no opportunity.
I guess I just don't understand the grant structure well enough, but I've asked this question before and I just can't seem to get an answer. Like, it's not that Pennsylvania applied for this component and got funded. We were told this was part of it and that they had to do it. And like I said, it's very vague directive of what you have to do. And it's quite a big ask. So that's why I don't understand how some states are not.
Yeah, and that's what I was saying, is it seems to be kind of almost more those who are holding the purse strings at the state level rather than state federal requirements or federal restrictions even. So, and that's frustrating too when it's state by state. And a lot of people have made comments that it would be nice if it was federal, or that all this funding was braided more effectively. So that, because there has, as far as I know, there are directives in the SOR funding to use it with, disease prevention, but I don't know. Yeah, we're not privy to a lot of that. It's interesting. Okay. I'm not seeing any, so Thaddeus said that they were able to get SOR funds to fund care coordinator for MOUD, HCV, and SSPs, methadone clinics, ASO, and FQHCs. Lots of acronyms there, Thaddeus. Right, so, it really does seem to depend on state to state and how you work it in. If you're making it a disease prevention thing, they seem to often turn up their nose at it. But if you circle it through and say that this is a MAT thing, or a substance use thing, then maybe they're more likely to fund it. So doing a fun dance, and it is hard that it's state to state. Let's see. So someone asked, okay. Thaddeus shared his email. If people want to email him, thank you, Thaddeus, as always, for sharing. And Amelia says that she's been asking about access to opioid settlement funds for HCV and harm reduction, be getting a lot of pushback. Yeah, we've been struggling with that too. Have other people tried to use opioid settlement funds or asked about that for any of this?
This is Emily in Washington.
Yeah.
Infectious disease services are explicitly named in the abatement document from the court, which means it's an allowable expense, but there's a lot of other allowable expenses too. So while it's included, and SSPs are also included as an allowable expense, I think, that's necessary, but not sufficient. So we'll see what happens. I mean, I keep using the analogy that this is going to be like the Hunger Games, and everyone's going to be, trying to keep themselves alive, and claw for the money. And so I don't know if we will see any of that money go to infectious disease services or SSPs, but it's at least in the abatement document from the court that that's an allowable use.
Yeah, I think there's going to be lots of, lots of Hunger Gaming. May the odds be ever in your favor, certainly. But I think it's important for us, and that's, I think, what most of us know who work in this area, is that we constantly have to keep reminding them that is in there. That is, don't forget about infectious diseases, because they will not keep us in mind if we don't remain the squeaky wheel. And maybe that's an interesting topic for an upcoming VLC or other NASTAD project, is to discuss maybe how we can continue to work to leverage some of these funds, especially the opioid resettlement funds. So great. Thank you, everybody. So speaking of leveraging funds and resources, oh yeah, good point, Isabel. That's great. She just mentioned that utilizing the TA meeting so we can invite our federal partners and discuss that further. I think that's a great idea. So can either of you speak to any resources or systems that in response to COVID that are being leveraged? Are you guys using any of those for your projects?
Go ahead, Melissa.
Okay. There was quite a bit of community outreach that happened with the COVID situation, and is still continuing to happen. And so it was a very large outreach team, and they have built an incredible network of community partners that we have been able to work with just for, I mean, this isn't just for Hep C testing, but just viral hepatitis vaccination. We're talking about Hep B vaccine, and also potentially maybe hepatitis C testing, but we've been able to partner with them. And we've also been able to work with our immunizations team. We had a separate COVID team, but now it's the lines are becoming more and more blurred, which is incredible. And that is a result of COVID. And so we've been able to really leverage those relationships that they have also and be able to inform their education materials. And so, yeah, I'm sure I'm missing a bunch. I'll think of more, I'm sure. Go ahead, Lauren.
Yeah, the only thing that we've been able to really, I guess, partner with the COVID side of the house in terms of the in terms of the substance use disorder piece is the DIS infrastructure that's being built with the expanded STD dollars. And that really hasn't gotten off the ground yet. We're still in conversation about exactly how that would look. But our STD partners have promised us access to several new DIS. I've asked if I could have access to, a more singular person, but ever evolving as they're just continuing to try to hire folks. They've just hired their supervisory structure. It's going to take a long time to get it all in place.
Yeah, we might as well use COVID to our advantage, right? And some of those funds that have come flooding in. I'm glad that your STD program is working with you. Have you noticed any other things that have worked or haven't worked well in these COVID years? Things that, how has COVID helped or hindered some of the progress that you've made on these projects?
From the state's perspective, I mean, it definitely has hindered us in our ability to spend down. Hiring delays, et cetera, has contributed to that. But it definitely has enabled us, I think, to carry out a lot of this work in the virtual space a lot more easily. So I think pre-COVID, our substance use disorder treatment providers probably would have been much more keen to in-person trainings and engagement. And our Penn State contractors were definitely on board to do that, but I think the breadth of what we've been able to do has been expanded because of the virtual space.
So I second that, Lauren. It has given us the ability to broaden our reach to providers who may not have had the time or interest in especially treating hepatitis C. And so we've been able to really develop more intense relationships, I guess, with clinics and with providers also, again, because we were afforded that time. So our relationships have become more intimate, and now that we're moving away from COVID, we've maintained that. And so it's been really incredible, I guess, seeing how, I mean, again, how that's really informing some of our other technical assistance programs that we're providing. So it's, I'm only going to talk about the positive COVID effects.
Nice. And I'd like to really get to this in our last couple of minutes is, can you speak to any do's or don'ts of engaging with community partners that serve people who use drugs? Any suggestions you have there or lessons learned? It's a pretty broad question to answer in a couple of minutes, but go ahead.
As we're just really starting, I think, to get to the individual level, I think it's helped us that we've been cognizant of the landscape ahead of time. We had an additional DOH contractor working on our team that we had hired through a contracting service as our project manager, and she came with some drug and alcohol experience. And she really just emphasized the need to, meet the facilities where they were in terms of risk assessment. So she felt like the messaging around opt-out testing could be negatively perceived by the breadth of drug and alcohol providers out there. the progressive nature is variable. So yeah, I thought that was helpful. That really was, we had a struggle with that at the beginning, I think, from internally with our Penn State and Health Federation contractors, really on the side of, we need to approach this as a universal opt-out method, but understanding the risk assessment approach and how it's embedded in the drug and alcohol landscape, I think was really helpful for us to keep at the forefront of our minds.
Sorry, along with that, Lauren, did you utilize PWUD at all in developing your marketing campaign or other people with lived experience?
No, unfortunately not. That should have been part of it, 100%. But we were, as always, crunched for time to spend down and get it out before the digital market became too expensive with political ads. So, yeah.
I hear that. I hear that. Melissa, do you have any do's or don'ts suggestions on working with agencies who work with PWUDs?
Yes, listen. That is ask questions, be curious, and listen. And being able to take what you hear and taking that curiosity and doing the research on your end when you go back to the office and trying to figure out, again, I think it's really important with the systems level changes, listening to what your partners say, figuring out what their barriers are, and then taking that back with you has been, I think, really important for us.
Yeah, and in the along those lines, I think it goes along with kind of what Lauren, what you were saying too, is a good thing is that you all are informed and have that relationship with PWUD as well as your community partners. So it's not like you're somebody who is coming in who knows nothing and doing this. So I think that ongoing listening and interaction really helps you then be, not that you should replace people with lived experience, but at least it helps that you're somewhat informed.
Yep. I know we only have like a minute left here, but the original copy for the digital media campaign said something effective: I'm not afraid of HIV and Hep C. And our partners internally in DOH were up in arms that that's not the message. We cannot say that. And they were really trying to, come from an anti-stigma lens. So at least we had that opportunity to weigh in. And we changed it slightly to sort of, I'm not afraid of the testing itself. So yeah.
I love that though. And that's, I think, trusting all of us that we do have that experience and that lens, and we can speak sometimes when necessary for our partners and our clients and participants. So that's excellent. Thanks, everybody. As usual, this goes so fast. I always wonder how we're going to fill an hour, and then we could probably fill 2 or 3. So thanks again to Melissa and Lauren for sharing your wonderful experience with us, and then following up with sharing some of your resources that Isabel will send out. And then I just wanted to have you note in the chat that we do have a survey for this session. We would love to have you fill it out. It's super short and fast, and it really helps us. Again, since this is our year, we've done a full year of these now, and you can also access the VLC microsite and all the recordings from the previous ones. All those links are in the chat, and then feel free, as always, to email hepatitis@nastad.org for any questions or any other information. And thanks again to everybody who's just been here and given time to this discussion. And again, a special thanks to Melissa and Lauren. Thanks, everybody.
Thanks, Heather.
Thank you. Bye.